Hello, hi, and greetings everyone. I think people can see me. Finally, it was settled down. Can you see me now at least? Yeah, I think so. I think people can see me. So if you can see me and hear me, you can put a thumbs up button. Yeah, I think I'm trying to optimize my screen's resolution. Just hold on. Hi, Vikram. Yeah, good evening. So I think my screen resolution has got a bit better now, hopefully, and you all people can see me and hear me now. Okay, so today I want to take another case in toxicology because my YouTube sessions, most of the time, I used to cover toxicology as such. So I wanted to cover another session on toxicology from last week's case. I thought I would be discussing on paracetamol poisoning, that is acetaminophen poisoning. That's what we're going to discuss in this particular topic, this particular session. So it's going to be a 1 hour session. Sorry for the delay because I think I have some problem in the OBS software to stream. So that's why it got a bit delayed. So not an issue. So we'll try to start the session as of now. So we're going to discuss on the paracetamol poisoning, acetaminophen. So we have a lot of things to know about this acetaminophen poisoning, right from the normal amount of doses that you have to take to the toxic doses that you're going to generate with acetaminophen. At the same time, you have to know about the mechanism on the metabolism of acetaminophen so that you will understand why acetaminophen toxicity is going to result in liver failure. And at the same time, you also have to understand the fact that there are certain things which are important in assessing the treatment. So all these things are very important to know. So we are going to start with the normal therapeutic doses of acetaminophen. So what is going to be the normal therapeutic dose of acetaminophen? What is the normal therapeutic dose? How much is going to be the therapeutic dose of acetaminophen? Anyone? Till how much you can give, and what is the maximum dose that you can reach in the therapeutic principle? No idea. So typically speaking, 100 gram, my god, 100 gram, like that is something shocker. Don't give up to 100 gram, really, and that's really toxic. 100 gram is not toxic, anything more than 10 gram is toxic. 3 gram. So, anyways, usually we give 325 to 1000 milligram per dose. So, that is the usual per dose we generally tend to give. And at the same time, you can give the same dose you can give every 4 to 6 hours, which means the maximum dose that you can give without toxicity as far as adults are concerned is approximately 4000 milligram. That is approximately 4 grams. 4 grams is the maximum amount of dose that you can safely give and absolutely give without any toxicity. So that is the maximum dose that you can reach. But in children, you have to tell in body weight form, because in children you cannot just like that tell like 4000 milligram or just 1000 milligram per dose. You have to use in the form of milligrams. So children, you can give 10 to 15 milligram per kilogram per dose, as in the case of children. Or you can go up to a maximum dose of, this is 4000 milligram per day. I'm not talking about per dose. Per dose you can give only up to 1000 maximum, and per day you can go up to 80 milligram per day, per kilogram per day. So this is the maximum amount of dose that you can give in the case of children. As far as adults are concerned, 4000 milligram is the maximum dose that you can absolutely give without any doubt in the safety. So this is the dose that you are going to achieve. So maximally. But what about the cirrhosis patients? Cirrhosis and chronic liver disease patients, what is the dose that is safe as far as cirrhosis is concerned? How much you can give? In cirrhosis, it's half of what you give for the normal adults. It's approximately around 2000 milligram per day or 2 grams per day. So in cirrhosis patients and in CLD patients, it's better to restrict your dosing up to 2000 milligram per day. Still, you can give paracetamol. It's not like you cannot give paracetamol to this particular group. You still can infuse paracetamol, but keep your doses up to 2000 milligram per day. For example, if I'm going to give 1 gram of paracetamol per dose in a normal adult, in a cirrhosis patient, I'm going to start with probably 500 milligram per dose of paracetamol, and I'm going to give approximately once in 6 hours, that is 4 times a day, that is 2 grams per day. So that is the dose that I'm going to use as a maximum limit as far as cirrhosis is concerned. But what about the toxic doses? When you're going to call, the paracetamol dose is going to be toxic. So what is the toxic dose beyond which it is toxic? So there are something called single dose kinetics, and here something called a cumulative dose kinetics, because a person who's taking a suicidal dose or ingestion of paracetamol may take as a single dose, or probably they may take a number of doses over a period of time. That might be cumulative dose also, or probably a child who's unaware of this paracetamol tablets and its toxicity might be taking like a candy now and then. So no child takes paracetamol as a candy, but anyways, if they take something similar to that, so that will result in formation of a cumulative dose. So what is the single dose toxicity with relation to paracetamol, and what is going to be the cumulative dose toxicity with relation to the paracetamol? So to be frank, in adults, as far as the total dose is concerned, 7.5 to 10 gram per day. Anything beyond that, anything more than the 7.5 to 10 gram per day is going to be regarded as a single dose toxic level. So where you can keep for exams 10% as a cutoff, that's a single dose toxicity. Or as far as children are concerned, anything that exceeds 150 milligram per kilogram is what we refer to as a toxic dose. If they take more than 7.5 to 10 gram per dose, or if they are going to take more than 150 milligram per kilogram as far as children is concerned per dose as a single dose, is what we refer to as a single dose toxicity or a single toxic dose. If it's a cumulative, the patient is taking for a large period of time. So obviously, if they take 2 tablets now, maybe 2 tablets after half an hour, or 3 tablets after 1 hour. So now there are 2 things that are going to be under consideration. One is the metabolism that is going on already. At the same time, the accumulation of the paracetamol in the body. So both has to be matched. So you can relax a little bit the cutoff. So if they take more than 12 gram over a 24-hour period. So if the cumulative dose exceeds more than 12 gram per day, so in this state again you're going to result in paracetamol toxicity. So this is another condition. So when can you tell it's a definite toxicity? Which means these are cut off for probable toxicities, but there is something called a definitive toxicity, beyond which no matter what, you will definitely end up with a toxicity, irrespective of your race, irrespective of your liver status, irrespective of the liver protectants that you're taking already, doesn't matter. Beyond this dose, there will be a definite paracetamol toxicity. That is when you're going to reach a dose of more than 350 milligram per kilogram per dose. So if you're going to reach this dose, definitely there is going to be a lot of risk of toxicity that you're going to encounter. So you have to know this dose. So with this dose, you're going to result in 100% toxicity without a doubt. That is more than 350 milligram per kilogram per dose, or more than 350 milligram per kilogram of paracetamol distributed over a 24-hour period. So beyond this, there is a 100% toxicity. There's no doubt about that. Okay. So now we have discussed on the dosing kinetics of paracetamol. Now it's better to move on to the pharmacokinetics. Why paracetamol causes toxicity? Can anyone tell why paracetamol causes toxicity? Any reason why paracetamol should cause toxicity? paracetamol is not a safe drug by any means. In the sense, like, always when you take in a limit, it's fine, but whenever the dose exceeds a certain limit, it's going to be toxic. So which means paracetamol is not at all safe by any limit. So if you wanted to die really, if you take 30 tablets of 1 gram paracetamol tablets, 100% you're going to die if you don't go to the hospital on time. So there's no doubt about that. So anyways, they are going to cause liver damage to ST. There's no doubt about that they're going to cause liver damage. But how they are going to cause liver damage is the question. So Synlaxis is right, so it's going to cause, sorry for that, my computer just spilled over it. Synlaxis is right. So the mechanism of how paracetamol causes toxicity is going to be NAPK. Yes, NAPK is the reason why they cause toxicity, but how NAPK is formed is the question. How it's going to be formed. So first, let us see how paracetamol is metabolized normally. So acetaminophen initially, majority of the acetaminophen, let me draw like this. Majority of the acetaminophen is going to be shunted towards a certain set of metabolism referred to as sulfation and conjugation. So they're going to have sulfation and they're going to have glucuronidation. So this is the major metabolism of paracetamol, where majority of the times, 95% of the paracetamol is actually metabolized through this pathway only, either sulfation or glucuronidation. So this is what we refer to as a conjugation. And majority of these products will be excreted in the urine. And there is some amount of paracetamol, like approximately 1% of paracetamol, that is excreted unchanged in the urine. So that is not important for us. But anyways, majority of them, almost 95% of the paracetamol is generally conjugated. And they're going to be either sulfated or glucuronidated. And the glucuronidated and sulfated products are going to be entering the urine. But there is some amount of paracetamol, like approximately 5%. There is some amount of paracetamol, like approximately I can tell 5%, which is going to be metabolized by the cytochrome P450 group. If you can tell what is the exact cytochrome enzyme, that is very, very important for the metabolism of paracetamol, I'll be very happy. I'll come back to that. Before that, I'll expect the answers in the box. So 5% of the paracetamol is going to be metabolized by the cytochrome P450 group. These are cytochrome enzymes because they absorb a specific wavelength at 450 nanometer. So that's why we call them as cytochrome P450. And where they're going to form this toxic product called NAPK. So NAPK is a very toxic product that they are going to form. So what is the full form of NAPK? It is called as N-acetyl para benzoquinonimine. So that's called benzoquinonimine. So that's what we called as NAPK. So N-acetyl para benzoquinonimine. So that is what we refer to as NAPK, which is going to be an extremely toxic product. So many students have got it right. So Synlaxis is right and Neeraj Sharma is right. It is cytochrome 2E1. So that's going to be the cytochrome P450 enzyme that is going to metabolize the paracetamol. And even though they form this toxic NAPK, normally we do have this glutathione to neutralize. So we have this glutathione in the liver that neutralizes this NAPK and prevents the heterotoxicity. Neutralizes the NAPK and prevents the heterotoxicity. Suppose in cases of paracetamol toxicity, so what's going to happen? Suppose if I'm going to encounter a patient with extremely high dose of paracetamol, so something else is going to happen. So like for example, now since there are a lot of doses of paracetamol is there, this conjugation, that is glucuronidation and sulfation step, will be fully saturated and they have a limit. So they will be saturated. They will be completely saturated. And yes, they will be excreted in the urine, but it will be fully saturated. But since there are so much of paracetamol that is still left, a lot of paracetamol is still left, and conjugation pathways are already saturated completely, and a lot of paracetamol is going to now spill over to the other pathway. to produce NAPK. So now the cytochrome will take over and there will be increasing amounts of paracetamol that will be shunted towards the cytochrome pathway. That is 2E1 pathway. So now they are going to produce increased amount of NAPK. Obviously, yes, the glutathione will try to neutralize this increased amounts of NAPK, but over time this glutathione stores will be depleted. So the glutathione stores in our body is actually limited. That's the most important catch point here. The glutathione stores are actually limited in this case. So because it is limited, over time this NAPK neutralization will take a huge hit because the glutathione resources will be depleted over a period of time. So now this NAPK is going to result in hepatotoxicity. So that's how paracetamol is going to result in hepatotoxicity. It's because of the formation of this toxic product called NAPK. So the idea of treatment of paracetamol is very simple. So you're going to try to give extra sources of glutathione. So now we are going to replenish this glutathione. So if we are able to replenish this glutathione, they can conjugate more and more NAPK and prevent the hepatotoxicity from happening. So how you are going to replenish this glutathione? By providing a substance called N-acetylcysteine. N-acetylcysteine is a substance that is able to neutralize, replenish the glutathione stores so that they can capture more and more NAPK and they can prevent the further hepatotoxicity. So that is the idea here. So to be honest, NAC is supposed to be an antidote to paracetamol toxicity, but to be honest, it's not a direct antidote to paracetamol. It doesn't bind to paracetamol, but it prevents the toxicity of paracetamol by neutralizing the NAPK through glutathione replenishment. So that is how your N-acetylcysteine is going to work, which means it's not a direct antidote for paracetamol. But anyway, still it's going to work as an antidote for paracetamol toxicity, which is really, really important to understand. So this is how the paracetamol toxicity is going to work. And what is going to be the pathology? Everyone knows that. So what is the typical pathology that you're going to see with paracetamol poisoning? What is the pathology? What's going to happen with paracetamol poisoning? Anyone? What is the typical pathology with paracetamol poisoning? Students must be knowing, right? So this is what you have been studying from the second year, I guess. Yes. Centrilobular necrosis. So that's what we're going to see. So typically centrilobular area is considered as zone 3. So there is a separate class where we'll be discussing about the zones of the liver microarchitecture. So in that there is an area called zone 3 that is called centrilobular necrosis. And Shaurya is answered as macronodular cirrhosis. To be honest, paracetamol is something which never causes cirrhosis. That's very, very important. So it's not micronodular, it's not macronodular. So paracetamol is typical of acute liver failure. It never causes a chronic liver failure, which means paracetamol toxicity is like an all or none law. If you recover completely, 100%, or you die. That's all. There's nothing called in between. You go for a chronic liver disease or a chronic liver failure. It's impossible with paracetamol poisoning. So there is absolutely no sequelae as far as paracetamol poisoning is concerned, which means what I'm going to talk about is the long-term sequelae. There is no long-term sequelae as far as paracetamol poisoning is concerned. It's all about acute liver failure and death. There is no chronic liver disease. There is no portal hypertension. There is no chronic liver failure, and there is no cirrhosis with paracetamol toxicity. There is no long-term sequelae, which is a very, very important point to understand with regards to paracetamol. All you have is acute liver failure. Whether you die during acute liver failure or you recover from acute liver failure over a period of time with or without treatment. And once you recover, 100% recovery. There is no sequelae at all. And similarly, you have clinical features which can be distinct into 4 classic groups as far as paracetamol poisoning is concerned. You have 4 stages as far as paracetamol is concerned. So I can tell the time frame and what will be the actual clinical feature in that particular stage. So you have something called a stage 1, which happens in the first 24 hours after ingestion of paracetamol. Most of the time, patients will be completely asymptomatic during this phase, which means they may not have any evidence of liver damage or they may not have any problem at all, which means they can have a normal liver function test. Or a few of the patients may have very non-specific complaints in the form of probably a nausea and vomiting or probably a malaise. So they might have a nausea and vomiting or probably a malaise. So that's what these patients can have. Absolutely non-specific. And that's because paracetamol is something that induces something called a gastroparesis, where the contraction of the stomach will be very poor. So that is the reason why they get this gastroparesis. And because of the same, they can result in nausea and vomiting. So in the first 24 hours. So very non-specific symptoms, or they can be completely asymptomatic. But the most important take-home point is the fact that they have a normal LFT, which is a very important take-home point. Okay. Then we have the second stage, which typically happens around 24 to 72 hours, where there will be clinical improvement. Clinical symptoms will improve, which means some patients may believe that their symptoms have improved and they even symptomatically they recover from paracetamol toxicity, which means they completely become asymptomatic even if they are symptomatic during the first phase, which means clinically they tend to improve, but LFT abnormalities will start. LFT abnormalities will start. I can write as LFT problems. LFT problems will start and they will progress, which means there will be elevation of liver enzymes. So in other words, I can tell there will be elevation of liver enzymes. Very importantly, it's the ALT that's the most important. So there's going to be elevation of liver enzymes, which is going to be of very, very high clinical importance. Then you are going to enter the stage 3. In the stage 3, which typically happens around day 3 and day 4. So I can write day 1 is the stage 1, day 2, day 3 is stage 2, and day 4 is the typical stage 3. So 72 to 96 hours. So that is the time frame for stage 3. This is the time where symptoms will reappear. Whatever symptoms they had in stage 1, like nausea, vomiting, will start reappearing, and the patient may have a hypochondral pain, very non-specific, but still the symptoms might reappear during the stage 3. And at the same time, LFT problems will reach its peak. Which means your transaminase levels will be at peak. For example, your ALT levels may be in thousands and 10,000s. There are very few diseases which cause ALT, AST, that is the liver enzyme levels in the thousands and 10,000s. First one is the drug toxicity, like paracetamol toxicity. Second one is viral hepatitis, which can produce ALT and AST in the thousands. And third one is the ischemic hepatitis. There is an entity called ischemic hepatitis, which can result in ALT and AST in the thousands and 10,000s range. So there are only 3 conditions for exams that you have to know, which can cause AST and ALT in the thousands. First one is almost going to be the paracetamol poisoning or any other drug-induced toxicity. So which means the symptoms are going to reappear in stage 3 and the LFT abnormalities will begin to peak, which means you're going to see the maximum amount of liver enzyme elevation during this phase. And this is the time where the patient starts developing liver failure as well, and this is the time where the patient most often dies also. So liver failure is the usual sequelae in this time. So 50% of the patients will have liver failure and they'll be having coagulopathy, encephalopathy. They start developing jaundice. Jaundice is a sign of liver cell failure, and predominantly jaundice will be of indirect bilirubin rather than direct bilirubin. That's what paracetamol toxicity is all about. They're going to cause indirect hyperbilirubinemia rather than a true conjugated and direct hyperbilirubinemia. Apart from that, they start developing multiple metabolic complications. They start developing multiple metabolic complications during this stage, like lactic acidosis, hypoglycemia, and so on. And they can develop acute kidney injury as well during this particular phase. And usually the overall incidence is less than 2%. Of those who are going to ingest paracetamol is going to develop acute kidney injury, and most often this, if you take the biopsy from the kidney, they will resemble acute tubular necrosis. Please understand the fact the liver failure is due to NAPK formation. We know that But the renal failure is not due to NAPKI. It's direct paracetamol problem. Straight away due to paracetamol itself, it's not due to NAPKI. So that is the reason why a patient who's having a renal failure because of paracetamol toxicity, NAPKI won't be, your NAC won't be helpful. NAC will be protective for liver injury, but NAC may not be protective, or NAC will not be protective for the case of AK that is associated with paracetamol poisoning. So which is a fairly important point once again. And finally, you are going to enter the phase 4, that is beyond 96 hours. Time frame is beyond 96 hours. You are going to go into the road to recovery. That's a recovery stage usually. So the patients are going to land up in recovery beyond 96 hours. That's what I wanted to tell. Suppose if they recover, recovery is generally 100% and usually complete within 7 days. Complete recovery within 7 days, which means there is absolutely no sequelae because of paracetamol poisoning. There is absolutely no sequelae. You're not going to get any long-term problem with regards to paracetamol poisoning. If they recover, it's 100% recovery. And the recovery is almost complete by approximately 7 days of time. Okay. So now we have discussed about the clinical features also. But what are the clinical predictors of toxicity? What are the things that are going to predict the toxicity clinically? What are the clinical predictors of toxicity? Obviously, the first clinical predictor that predicts toxicity is the dose. Dose is the most important. So because the paracetamol toxicity is generally dose dependent and dose related, so more the dose you take, more is going to be the toxicity. The first one is going to be the dose, which is the most important clinical predictor as far as clinical practice is concerned. And number 2, your delay between ingestion and treatment. So if you're going to have more delay between ingestion and treatment, so likely you're going to end up with more problems. So delay between ingestion and hospitalization, or ingestion and beginning of the treatment, is another important clinical predictor of toxicity. And number 3, alcohol. Alcohol, you have 2 options. One is acute alcoholism and chronic alcoholism. So which is more dangerous, acute alcohol or chronic alcohol? Acute alcoholic binge, when you're taking paracetamol along with alcohol, is dangerous, or chronic alcoholism is dangerous, which means alcohol is being taken for a long time. I'm telling the patient is not having liver disease but just taking alcohol for a long time. Which is more dangerous, acute or chronic alcoholism? Yes, actually, Neeraj is right. Your chronic alcoholism is going to be more dangerous than acute alcoholism. But Neeraj has to tell why acute alcoholism is not dangerous. What is the reason why chronic alcoholism is dangerous? Okay, you're telling chronic because it's already damaged. Actually, it's not the case. Remember the fact that alcohol and paracetamol competes for the same cytochrome enzyme. So, and they compete for the cytochrome 2E1. So, in acute alcoholism, so whenever the patient is having an acute excess intake of alcohol, so they're going to compete with paracetamol. So, which means they're going to compete with paracetamol, and alcohol will use the COP2E1 to get metabolized, and usually you don't result in formation of NAPKI from paracetamol. So that is the reason acute alcohol is actually a little protective against liver injury. But whereas chronic alcoholism, the problem with chronic alcohol is, chronically if you're taking alcohol, this alcohol is going to induce the cytochrome 2E1 enzyme, which means they're going to cause hyperplasia and induction of the cytochrome 2C1 enzyme, which now will result in more conversion of paracetamol to NAPKI. And the NAPKI capacity will be, the cytochrome 2E1 capacity to oxidize paracetamol will be a little more in this setting, because alcohol tends to induce the cytochrome 2E1 enzyme, which means it's going to stimulate the cytochrome 2E1 enzyme, especially if you are a chronic alcoholic. So more paracetamol will be converted to more NAPK, resulting in more hepatocellular failure. So that is the reason why chronic alcoholism is more dangerous than acute alcoholism. And number 4, predictor number 4. Fourth predictor is malnutrition. You can imagine that malnourished patients will have already lesser stores of glutathione, so lesser NAPK can be neutralized. So because of the lesser glutathione stores in these patients, so they are going to produce more NAPK, resulting in more liver injury, malnutrition. Number 5 is smoking. Smoking is considered to be a clinical predictor of paracetamol toxicity because smoking will induce the cytochrome 2E1 enzyme, resulting in more production of toxic NAPK. And 6th, age more than 40 is going to be having high risk of development of paracetamol toxicity because they tend to produce more NAPK compared to the other population. Actually, in contrast, age less than 5 tend to have a low risk of development of paracetamol toxicity. Clear? Suppose if I'm telling chronic liver disease patient, you're going to have more risk or lesser risk? That's my question. So whether they have more risk or whether they have lesser risk. Chronic liver disease and paracetamol poisoning. So they're having more risk or lesser risk? That's my question. No idea. Okay. Chronic liver disease patients generally tend to have lesser risk of death compared to that of normal patients. The reason is because in chronic liver disease, there will be reduced levels of cytochrome 2E1. So there will be reduced levels of cytochrome 2E1 because the hepatocytes are already damaged, and there will be reduced levels of cytochrome 2E1. So that is the reason why chronic liver disease patients tend to produce reduced levels of NAPK. But the dose of paracetamol will be too much. It can cause other issues, but hepatotoxic risk is actually lesser with chronic liver disease because they tend to produce lesser NAPK because of the lesser amounts of cytochrome 2E1 enzyme. And you know why they produce central lobular necrosis? We have been discussing about this central lobular necrosis for quite a while. So why they should produce central lobular necrosis? What is the reason behind the development of this central lobular necrosis in patients with paracetamol toxicity? What is the reason? What is the reason? Because this zone 3 is the place. This zone 3 is the place where you're going to have increased amount of cytochrome enzymes. Cytochrome enzymes will be very much higher concentrated in the zone 3, which means there will be increased levels of CYP2E1 as well. So in the zone 3, so that is the reason why formation of NAPK will be more in zone 3. Because the formation of NAPK is more in zone 3, you will be resulting in development of this zone 3 necrosis, that is central lobular necrosis. That is the reason, because zone 3 is the one that's going to have maximum amount of cytochrome enzymes. That is the reason. Anyways, so now you know how paracetamol is going to kill the patient. Now we wanted to know what is the treatment. So what is the treatment and how will you manage in the emergency? How you are going to manage a paracetamol toxicity? So usually I used to give a mnemonic called RRSI dead. This is a famous mnemonic I generally tend to give. If you closely watch my previous toxicology sessions, I would have given this. That is referred to as something called RRSI dead, DEAD. So R stands for, people who have attended my previous class will be knowing this. Resuscitation, and another R stands for risk assessment, and S stands for supportive care and monitoring, and I stands for investigations and D stands for decontamination, and E stands for enhanced elimination. Somehow you try to eliminate the toxic substance more, and A stands for antidote that you're going to prefer, and D stands for disposition. Remember, this RRSI dead is a like very common and famous mnemonic that is seen in every emergency room, because based on this only you're going to treat the patient. So RRSI dead. So in this case, so what are the resuscitation I need? So is there really any resuscitation I need? Actually, usually resuscitation is not needed, and most of the times you don't need any resuscitation, which means there's no point. Many of the times it's not required. Usually resuscitation is very rarely required as far as paracetamol poisoning is concerned. Huge amount of ingestion. For example, like when the paracetamol levels in the blood exceeds 800 milligrams per liter. So I'll teach you about the Romac Method Nomogram, in that you're going to plot the paracetamol levels. So if the paracetamol levels reach more than 800 milligrams per liter, rarely, it's not required at all, very rarely, in doses where the paracetamol concentration, serum paracetamol concentration, acetaminophen concentration is more than 800 milligrams per liter. In this situation, it can lead to coma, lactic acidosis. So in this setting, you can resuscitate the patient. For example, a coma patient obviously has to be intubated, and a patient who's having a lactic acidosis has to be given fluid resuscitation, and probably if the pH is very low, you can start with bicarbonate infusions also. But anyways, very rarely it's required, especially in very significantly toxic cases, you might need a resuscitation. But apart from that, paracetamol toxicity is usually not an indication for aggressive resuscitation. And the second area where you have to concentrate is on hypoglycemia. Not only on coma and lactic acidosis, in extremely high dose of paracetamol ingestion, you can result in hypoglycemia, which is one of the very important effects of paracetamol toxicity, which I have discussed sometime. Or if the patient is having delayed presentation with hepatic failure, in that instance also you can start with resuscitation. So apart from that, resuscitation, what you have to know, is rarely required in the emergency. You usually don't require an resuscitation, because most of the paracetamol poisoning, when they come early, they will be completely asymptomatic. And then is the risk assessment. The next R is the risk assessment. So how you are going to assess the risk in a patient paracetamol toxicity? Most important thing is the dose that you have to know. Then what formulation they have taken. And third is the timing of ingestion, which is very important, because based on this only you have an element to treat, especially for a single dose. Similarly, what is the dose, how fast they have taken, whether they have taken it as a single dose or whether they taken it as a cumulative dose. So cumulative dose means you have some cushion, you have up to 12 gram cushion to produce toxicity. So cumulative dose, and at the same time whether the patient is symptomatic or asymptomatic. They may have symptoms or they may not have symptoms at all, symptomatic or asymptomatic. And these are the things that you're going to ask as a questionnaire in patients who are having suspected paracetamol ingestion, and you're going to do risk assessment. First is the dose, that's the most important. Second is the formulation with which they have taken, and third is the timing of the ingestion. That gives a lot of vital clue as far as paracetamol poisoning is concerned. And fourth one is whether they have taken a single dose or a cumulative dose. And fifth one is symptoms, and whether the patient is having symptoms or the patient is asymptomatic. That's what we're going to look out for. So now S stands for supportive care, which is largely not very important as far as paracetamol poisoning is concerned. And I stands for investigations. Tell me two important investigations that are important as far as paracetamol poisoning is concerned. What are the two important investigations that is important for paracetamol poisoning? Okay, LFT, no brainer. And in the LFT, my most important investigation will be the liver enzymes. ALT is the most important. Yes, serum paracetamol level. Serum acetaminophen level, one of the most important investigations. This is often not done in many institutes. I don't know why. They often start with NAC straight away, but this gives a lot of vital clue. If it is more than 800 milligrams per liter at any point, then it indicates severe toxicity, and you have to be very careful. And these patients will go for complications usually. So that's why serum paracetamol level is not only uh, therapeutic, but it's also going to help you in prognosis. It's prognostic as well. So serum paracetamol levels are very important. And third, you can do a lot of other investigations in the form of you can do lactate because paracetamol can cause lactic acidosis, or you're going to do glucose because high levels of paracetamol ingestion can result in hypoglycemia, which I've discussed already. Then you need a blood gas analysis. You need to know the pH because pH is one of the important indications for uh, emergency liver transplantation. So that's why this pH is very important as far as this blood gas is concerned. The lactate can also be found out through the ABG, arterial blood gas itself. Apart from that, you can do calcium, phosphate, magnesium as per your requirement. You can do. And since I have told you about the investigation, you have to know about the paracetamol nomogram. So you have a nomogram for treating paracetamol poisoning patients. So can anyone tell what is the nomogram called? What is the nomogram called? Yeah, I'll come back to that. What is the time frame to do a paracetamol nomogram? So just hold on. Before that, tell me the nomogram's name so that I'll move on to the treatment, how you're going to treat. Yes, that is what we refer to as a Romac Method nomogram. So I think so obviously, so this is going to be the Romac Method nomogram basically. So I've shown you this here. So this is going to be the Romac Method nomogram. So the importance of this nomogram is multifold. So what is the advantage of this Romac Method nomogram? So this is what we refer to as a Romac Method nomogram. So it's a very important name as far as exams are concerned. So you can see a line over here. So this is the hour of ingestion, right? So you're going to do paracetamol level at 4 hours, then I can repeat at 8 hours, then I can repeat at 12 hours, then I can repeat at 16 hours. And this is the nomogram line. So and I'm going to do a serum paracetamol level concentration. Suppose if my like paracetamol level is above this line. So for example, if I'm doing a paracetamol concentration at 8 hours, and if my paracetamol levels are more than this, so remember, the paracetamol concentration is given in two entities here. So one is in micromoles per liter, and on the right side we have milligrams per liter. In India, usually we use milligrams per liter formulation. Suppose if my paracetamol level at any point, probably at 12 hours if it's like this, or at 4 hours it's at here. So if it's more than this level, this particular line, if my paracetamol level is there, then that becomes an indication for N-acetyl system. Clear? So that's a very important point. So that's how this nomogram works. So what are the pitfalls of this nomogram? Can you tell where the nomogram works and where the nomogram does not work? Nomogram does not work in certain places. For example, this nomogram is approved only for single dose ingestion. Only for single dose ingestion, this nomogram will be approved. If it's not a single dose, this nomogram will not be beneficial. You cannot use this nomogram. Clear? Similarly, for example, if it's a staggered dose, staggered intake of paracetamol, or if it's a multiple dose, multiple dose toxicity. So in this setting, do not use this Romac Method nomogram. In this setting, the approach is something completely different and it's multidisciplinary. So I'm not going to use the Romac Method nomogram in this setting. Similarly, yes. Next thing, if the intake time is not known, obviously, like this nomogram clearly tells that this intake time is. I mean, the Romac Method nomogram is based on the intake time only, which means without knowing the intake time, you will not be able to determine the, prognosis, or you cannot tell whether you have to give NAC or not. In very early hours, yes, usually less than 4 hours, we don't do paracetamol levels. Usually, we tend to do paracetamol levels only at 4 hours. That's the usual idea. So before 4 hours, you cannot do. So that is again, it's a very simple thing that you can infer from the nomogram itself, really, because the nomogram actually starts from 4 hours only. Okay, you can see the line itself starts from 4 hours. Before 4 hours, there is no point. So there is no line at all. So which means if the patient comes within 4 hours to your emergency room or within 4 hours to your casualty, so you cannot take the paracetamol level in the first place because there is no nomogram for you and there is no guideline to guide you whether to give NAC at this point or not. So the first measurable level of paracetamol should be obtained at only 4 hours, and beyond that, if it's a single dose, most of the time it will be a single dose in your routine practice. So if it is more than 4 hours, then at 4 hours you take a paracetamol level and then accordingly you treat. But in India, we usually use the milligrams per liter dose only. So for exams, you can understand that at 4 hours, if it is more than 150, you can treat with NAC. And similarly, at 8 hours, if it is more than 75, so this comes around somewhere around 75. The cutoff at 8 hours is going to be around 75 milligrams per liter. So if at 8 hours, if it is more than 75, you can start treating. And similarly, at 12 hours, you can see it will be somewhere around 37.5. So if at 12 hours, if it is more than 37.5, you can start treating them. Clear? So these are the three values that you have to know for exams. If at 4 hours, if it is more than 150 milligrams per liter, at 8 hours, if it is more than 75 milligrams per liter, at 16 hours, if it is more than 37.5 milligrams per liter, so then you can probably start treating with NSL system. So we'll go back to the original one. So now we know the nomogram. The nomogram is nothing but the Romac Method nomogram. Romac Method nomogram. So as I told you, Romac Method nomogram is applicable only for single dose injections. You cannot use it for staggered dosing or multiple dosing because the pharmacokinetics there is completely different, and this nomogram lines will not be applicable in the first place. And number two, this nomogram will not be applicable in multiple tablet poisoning. So which means many of the times patients may not be aware of how many tablets he or she has taken, so they might be taking multiple tablet poisoning. At the same time, as I told you, within 4 hours, that is very early injections, you cannot use this nomogram in the first place, very early injection, because the first level where you can do is only at 4 hours. Similarly, each country will have different units. So in the sense, you have to know the country where you are living at. So each country will have different nomograms. The nomograms applicable in cirrhosis, yes, it's still applicable in cirrhosis. It's not like it's not applicable in cirrhosis. It's still, if it's a single dose, it's still applicable in cirrhosis. You can still use in cirrhosis because it is actually based on the paracetamol level only and doesn't depend on the liver function. So liver function is not a key criteria here. It's only about the time and the paracetamol level. So if it's beyond the cutoff, even in patients with cirrhosis or if it's a complete liver failure also, it doesn't matter, still you can treat. So not a problem. And what about decontamination? So next we have thought about this RRSI. So we have done the resuscitation, we have done the risk assessment, we have done the supportive care, we have done the investigations. Now we are going for the decontamination. Decontamination. How we are going to decontaminate this, guys? Decontamination is going to be based on activated charcoal, number one. The first one is the activated charcoal. So usually activated charcoal should be given within 1 hour. So, but for paracetamol, it is something different. how long you can give activated charcoal as far as paracetamol poisoning is concerned? Can anyone tell how long? For paracetamol poisoning, it's special. You can give activated charcoal to a longer period of time. So how long? It depends on what book you study. The general guideline, general consensus is the fact that you have to give within 2 hours. There is 1 hour extra gap as far as paracetamol poisoning is concerned. But if you study certain Indian textbooks like your API textbook, you can give up to 4 hours. But in general, overall, activated charcoal should be given within 1 hour. So why only for paracetamol? A little bit, like relaxed cutoff is there, where you can give the activated charcoal up to 2 hours or 4 hours. Why? Because paracetamol is something that causes gastroparesis. So it will be staying in the stomach for a relatively longer time. So that is the reason why probably, it is a little bit relaxed as far as paracetamol poisoning is concerned. You can give for a little bit longer time. So the guideline says that you can give up to 2 hours or probably up to 4 hours as according to the Indian guidelines as far as paracetamol poisoning is concerned. So if you are using immediate release activated charcoal, suppose if you are using immediate release activated charcoal, you can use up to 2 hours. If you are using delayed release activated charcoal, you can use up to 4 hours. So that's what, a small point that you have to know if you want to use. So what is the dose of activated charcoal that you generally prefer? The dose of activated charcoal is 1 gram per kilogram. That's the dose of activated charcoal that you are going to prefer. The maximum dose in any patient should not exceed 50 grams. 50 grams is the maximum dose of activated charcoal that you have to give. Clear. So then we have finished RRSI. Then E stands for elimination. I don't think paracetamol can be eliminated, and at the same time, it is not something that is dialysable, or you cannot use a hemofiltration technique, or you cannot use any forced alkaline diuresis to eliminate paracetamol. So there is now no way for that. So I'm putting just a negative symbol. So there is no elimination. And then we have the antidote, dead. So now we have the antidote. So we know what is the antidote here. Antidote is definitely N-acetylcysteine. There is no doubt about that. As I told you before, it's not a direct antidote, but it's an indirect antidote. So definitely it's an antidote. So that's what we're going to use. And the dose of NAC is highly variable. So, but you have some different dosings of NAC. So the mechanism of action of NAC is very simple. It's going to replenish the glutathione stores. That's how it's going to work, which we have discussed already. It's going to replenish the glutathione stores. And there are two protocols for giving NAC. So one is the 72-hour oral protocol, and second is the 20-hour IV protocol. So there are two protocols there. One is the 72-hour oral protocol, and second is the 20-hour IV protocol. So we have different IV protocols in different countries, but in India this is what is preferred, and even in United States this is what is preferred. This is called an accelerated IV protocol, and this is what we generally prefer. So that's the IV protocol that is followed, 20-hour protocol, and the oral protocol is 72 hours. So here, what is the loading dose that we are going to give? Here the loading dose that we are going to give is approximately 140 milligram per kilogram of N-acetylcysteine. Then it will be followed up with 70 milligram per kilogram 4th hourly. 70 milligram per kilogram 4th hourly for 17 doses. That is the minimum. I'm not telling the maximum. You can extend the number of doses as well. But typically we tend to give 17 doses every 4th hourly of 70 milligram per kilogram each dose. So initially load with 140 milligram per kilogram, then you're going to use a 70 milligram per kilogram dose, and you're going to give it every 4th hourly for 17 doses. That's a minimum, but you can extend, not a problem. IV dose, similarly you have to have a loading protocol. For IV loading, it's approximately 150 milligram per kilogram for 1 hour. So you're going to give 1 hour of 150 milligram per kilogram dose. This should be followed by a maintenance dosing of 50 milligram per kilogram for 4 hours. So you are going to give an infusion of 50 milligram per kilogram dose of IV N-acetylcysteine for 4 hours, then which will be further followed by 100 milligram per kilogram of N-acetylcysteine for 16 hours. So you're going to give 100 milligram per kilogram of N-acetylcysteine for 16 hours, which means otherwise I can give a dose of 12.5 milligram per kilogram per hour infusion for 4 hours, or I can give 6.25 milligram per kilogram per hour for 16 hours. So both are right. So either you give 50 milligram per kilogram for 4 hours infusion, or 100 milligram per kilogram for 16 hours as an infusion, or to be simplified, if I want to write, I can write 12.5 milligram per kilogram per hour for 4 hours, or 6.25 milligram per kilogram per hour for 16 hours. So this is what we refer to as a accelerated 20-hour protocol. Clear? So I'm going to use the infusion for 20 hours. Initially it's the loading dose that will not be calculated. So 20-hour protocol. Clear? So some facts on NAC. So NAC should be started as early as possible, as soon as possible. That is the best time to start with NAC. So the best time to start with NAC is as soon as possible. Even if it is within 4 hours, doesn't matter. Even if you don't have the nomogram, doesn't matter. If you have the evidence of toxic paracetamol doses, then you can use an N-acetylcysteine. So not a problem. But remember, the nomogram is not going to change. Irrespective of whether you use N-acetylcysteine or not, the nomogram is the same. So suppose if the N-acetylcysteine is already given, for that matters, it's not going to affect the blood paracetamol levels at all. So it's not going to affect at all. N-acetylcysteine is going to only help in neutralizing the NAB key. It's not going to affect the blood paracetamol levels at all. So which means the blood paracetamol levels will be the same. So still your nomogram will be beneficial if it's a single dose and all the rules are applied. Still the nomogram will be beneficial. Whether to continue with NAC or not, it will be useful. So you can start with NAC, alright, but whether to continue or not, you can use the nomogram once again, even after giving N-acetylcysteine as soon as possible, even within 4 hours. Or if the blood paracetamol levels are high after giving NAC, it's a strong indication to continue the NAC therapy. So still the nomogram will be beneficial. So that's very, very important to understand. So it's not like it will not be beneficial, still it is beneficial. So the best time to give is as soon as possible. There's no specific time for that. The best time is to give as soon as possible. But overall, if you ask when it will be beneficial or not, so whether it's beneficial or not, definite benefit you will achieve within 8 hours. If you start within 8 hours, you're surely going to get definite benefit if it's a paracetamol toxicity. So it's going to be of borderline benefit if you start within 16 hours, in 8 to 16 hours mark, and it's a very doubtful benefit. And the benefit will be extremely doubtful if you're going to start beyond 16 hours. So if somebody asks you what is the best time to start N-acetylcysteine, ASAP. Doesn't matter. Start as soon as possible. Then you can use the nomogram to determine the continuation of the NAC. Doesn't matter. So, but benefit-wise, definite benefit if you start within 8 hours. Borderline benefit if you start within 16 hours. But absolutely doubtful benefit if you start beyond 16 hours. So, you're not going to have that much amount of benefit as far as NAC is concerned. So, whether NAC can be given in patients with hepatic failure or not? Question, yes or no? So, you're going to answer in the form of yes or no. So, whether NAC can be given in hepatic failure? True statement or a false statement? Hepatic failure, you can give NAC or you cannot give NAC. Question. Patient is already having a liver failure. Yes, of course, there's no doubt about that. Even in hepatic failure, you can start with N-acetylcysteine. And second question I'm going to ask is, patient is having AST, ALT in the 10,000s. For example, patient is having AST, ALT of 12,502. I'm telling NAC is contraindicated because the AST, ALT is very, very high. So this statement is a true statement or a false statement. True or false? So AST-ALT is so much elevated, NAC is contraindicated. True statement or false statement? What's going to be the answer? It's a false statement. So which means what I'm trying to tell is AST and ALT has nothing to do with NAC administration. So nothing to do with NAC administration, which means irrespective of whatever the AST and ALT is, you can use N-acetylcysteine. So okay, let me go to the next question on NAC. N-acetylcysteine is protective for acetaminophen-induced renal failure. Acetaminophen-induced renal failure. It's a very common entity, acetaminophen-induced renal failure. Whether this statement is a true statement or a false statement. What is your take? N-acetylcysteine is protective for acetaminophen-induced renal failure. True or false? Yes, answer is false. N-acetylcysteine is only protective for hepatotoxicity caused by paracetamol. N-acetylcysteine is not protective for acetaminophen-induced renal failure. So renal failure is a completely different entity. It's thought to be due to direct toxicity of paracetamol on the kidney, probably due to some free radical generation, but the mechanism is different. So it cannot prevent the N-acetylcysteine-induced renal failure. So N-acetylcysteine is safe in pregnancy and children. True statement or false statement? Safe in pregnancy and children. This is the fourth question. True statement or false statement? Yes, true statement. N-acetylcysteine is safe in pregnancy as far as and children. So, in fact, in pregnant women, it is more safer. It's beneficial actually, because N-acetylcysteine. Next question comes. It crosses placenta. True statement or false statement? So, N-acetylcysteine crosses placenta. True statement or false statement? False. Okay. Most of the answers were right except this. It's a true statement. N-acetylcysteine crosses placenta. It crosses placenta. Actually, N-acetylcysteine crossing the placenta is thought to be one of the main reasons for fetal protectivity, which means N-acetylcysteine can produce fetal hepatic acetaminophen toxicity can produce the fetal hepatic necrosis as well. Because it produces fetal hepatic necrosis, N-acetylcysteine is thought to be beneficial for the fetal liver also because it crosses the placenta. So yes, it does cross placenta, and that is thought to be the beneficial effect on the fetal liver as well. Because acetaminophen crosses the placenta, and they can produce fetal hepatic necrosis, where N-acetylcysteine can prevent the fetal hepatocellular necrosis caused by the paracetamol. And what is the most common side effect of N-acetylcysteine? Most common side effect of N-acetylcysteine is vomiting, which has approximately 33% incidence, which means 1/3 of the patients generally tend to develop vomiting. And this is actually very questionable because vomiting may be due to paracetamol toxicity induced gastroparesis itself, and paracetamol toxicity on the GIT itself can cause vomiting. May not be really due to N-acetylcysteine, but this is a number that may not represent the correct statistics. Yeah, obviously it is not a very good smell. So N-acetylcysteine can cause vomiting 1/3 of the patients, followed by hypersensitivity reaction, and this is fairly common. Hypersensitivity reaction, which happens in approximately 10 to 20% of the individuals. Some form of urticaria and some form of rash they might get, some form of itching they might get. Often the hypersensitivity reaction is mild, so which means this is not a contraindication for giving N-acetylcysteine, which means you can continue giving N-acetylcysteine, so it's not a problem. Chintu Sheth, please end the session, sir. Why you should end the session? What is the point in ending the session now before completing? So, not a contraindication at all. So, vomiting, suppose if the patient vomits, what are you going to give? So, what are you going to do? So, you can repeat the dose. Suppose if the patient vomits within 1 hour of the previous dose, then you can repeat the dose. So, which means you have to repeat the same dose. Repeat the same dose one more time. Suppose in case if the patient vomits within 1 hour of the previous dose. So you're going to repeat the same dose. Similarly, if the patient is not tolerating, intolerable. So intolerable for oral N-acetylcysteine, then in this case you can move to the IV N-acetylcysteine. That's better. So in that case, suppose if the patient is not tolerating the oral N-acetylcysteine at all, and in that case, in that regards, you can go back to the IV N-acetylcysteine, which is a very good thing. And what are the indications to stop treatment? Anyone? So what are the indications to stop treatment? So when can you start? Okay, you can go and sleep, Chintu. Nobody's stopping you from sleeping. Thank you. So what are the indications to stop treatment? There are 3 indications to stop treatment. First one, no, it's not like IV is preferred anyways. So you can follow any protocol. Whether you can use oral protocol or you can use a IV protocol. IV is preferred because many of these patients will have nausea and vomiting. So sometimes they may not tolerate the oral dosing. So that is the reason it's been traditionally told that IV is preferred, but it's not like that. You can use any dosing, IV as well as oral, as far as the patient is tolerating. Doesn't matter. First indication to stop treatment is undetectable paracetamol levels. So the blood paracetamol is undetectable. Almost it goes below a particular level, undetectable paracetamol levels. And number 2, if ALT is normal or if the ALT declines or if the ALT is decreased by more than 50% of initial value. So whatever initial value of ALT you are seeing, if the patient presents late, if there is at least 50% decline from the previous value or the initial value, so then you can stop the N-acetylcysteine. Then third indication is if INR is less than 2. So in that case, the initial INR should be elevated. So that's it. The most usual indication of stopping the N-acetylcysteine treatment is undetectable paracetamol levels. That is the usual indication. Or second indication sometimes can be used if at all the initial ALT is elevated. If it decreases by 50% compared to the initial value, so this is where you stop the treatment. So which means it's not like you have to give only for 72 hours of N-acetylcysteine or you have to give only 20 hours of N-acetylcysteine. It's a protocol for a single regimen. You can continue the regimen. It's not like you have to give only for 7 hours, you have to give only for 20 hours. You can continue the infusion or you can continue the oral N-acetylcysteine till you reach your endpoint. That is undetectable paracetamol levels, ALT normal or decline by more than 50% from the previous initial value or INR less than 2. So these are the indications for stopping the N-acetylcysteine treatment. Clear? So transplantation, there are many indications for transplantation, but we generally tend to follow the King's College criteria. King's College criteria, that's what we follow. King College criteria for transplantation. The patient is on warfarin, is the relative value from the baseline of patient to stop N-acetylcysteine? That's a good question. But if the patient is already on warfarin or the patient is already having liver failure, why you want to use INR in the first place? INR becomes invalid in those settings. So you cannot use INR for that. So the patient is already on warfarin or if the patient is already having a cirrhosis and a liver failure, not due to paracetamol anyways, in that setting, INR will be invalid. So you cannot use INR to predict the N-acetylcysteine treatment. So it's better to use the other cutoffs like undetectable paracetamol levels. That's why I told you that's the most important. Undetectable paracetamol levels is one of the most important reasons for stopping the treatment with N-acetylcysteine. And obviously, transplantation, we are going to use the King College criteria for transplantation. So we all know what are the King College criteria for transplantation. So for paracetamol poisoning, you have a special cutoff. I mean, you have a non-paracetamol poisoning related cutoffs for transplantation according to King College criteria. But for paracetamol poisoning, the first and the most important is the admission pH. That's why I told you the pH is one of the very important investigations. Arterial blood gas. If the admission pH is less than 7.3, or if lactate is more than 3.5, post fluid resuscitation. You have done a good amount of fluid resuscitation, but still if your lactate is persistently more than 3.5 despite fluid resuscitation, or if the admission pH is less than 7.3, so then that becomes the definite indication for liver transplantation. This is the major indication, which means it's a definite indication for liver transplantation. Clear? Second are minor indications. If you have all 3 out of 3 that is present. If all 3 out of 3 which I'm going to mention are present, then that becomes an indication for liver transplantation in paracetamol poisoning. Grade 3 and 4 hepatic encephalopathy, and INR more than 6.5, which is defined as prothrombin time more than 100 seconds, or INR more than 6.5, and the serum creatinine more than 3.4 milligrams per deciliter, or 300 micromoles per liter. So if all 3 out of 3 are present, grade 3 and 4 encephalopathy, INR more than 6.5, along with serum creatinine more than 3.4 milligrams per deciliter, if these are there, these also become the indication for liver transplantation as far as paracetamol poisoning is concerned. Clear? So, 2 criteria. One is the admission pH, that is less than 7.3, or lactate more than 3.5 post fluid resuscitation. Then all 3 out of 3 are there, like grade 3 4 hepatic encephalopathy, INR more than 6.5, and serum creatinine more than 3.4 milligrams per deciliter, renal failure. So if all 3 are there, then this becomes an indication for liver transplantation according to King College criteria. So I think we have discussed in detail about the paracetamol poisoning. We have started with the therapeutic dosing, then we have gone to the toxic dose, then we saw the pharmacokinetics and the mechanism of toxicity, pathology behind it, clinical features, and the 4 distinctive stages of paracetamol poisoning, and the recovery, which is usually complete and 100%, no sequelae, no cirrhosis, no long-term complications with paracetamol toxicity. Either it kills you now or it doesn't kill at all later as well. And the clinical predictors of paracetamol toxicity, which is very important for exams, and what are the measures for treatment in the form of this RRSI dead, and resuscitation, risk assessment, supportive treatment, then investigations. What are the investigations that you have to do? What do you mean by Romac Method Nomogram, where it is applicable, where it is not? Then decontamination, antidote, what is the definitive dosing of paracetamol? And finally, disposition. So when to stop treatment, I have told you. So this is what we refer to as disposition or discharge, when to stop treatment and when to discharge. That is the final D in RRSI, dead. So all these things we have discussed in detail. So there are even more principles on paracetamol poisoning, but if you know this much for exams, I think it's more than enough. I think we'll stop here and let us see in the next class. Good night. So okay, fine. So anyways, I'm going to bid adieu. Good night. Thank you very much.